Okay, we are live now.
Okay. Good morning, everyone. I'm going to call this meeting to order and at the same time say how excited I am and happy that I am that we are all together for the first time in almost 5 years, most of us. Certainly happy to be chairing our meeting as we end out our year. So with that, I am now calling to order our annual meeting. The purpose of the annual meeting under our bylaws is to elect a vice chair of the board. And so at this time, I believe I'm calling for a motion to elect a vice chair.
I move to nominate Lane,
Second.
who has done a wonderful job as our current vice chair. And we would be delighted if you would serve again.
Thank you. Thank you. I believe I'm going to
Ready for vote?
Yes.
Okay, so, Commissioner Caljo.
Aye.
Michael Cherno. Willie is not in attendance. Elaine,
Yes.
Bella,
Yes.
Eric,
Yes.
Dana. She's remote.
Yes.
Thank you. Robin,
Yes.
Dimitri,
Yes.
Nancy,
Yes.
Yes.
thank you. And I'm going to invite Undersecretary to open the meeting. Oh, yes. Okay, that's good. Thank you, everyone.
Well, welcome to the connector meeting. It's actually my first connector meeting because Karen Sang used to stand in for the secretary and she has now moved over. Where is she? Is she here? No, she has moved over to,
She's moving. Almost.
in
Couple more weeks. We can't wait for that.
a couple, so we can go ahead and get started.
Okay, and with that, I just want to entertain a motion to adjourn based on the vote. And also acknowledge that the motion did carry.
So moved.
Second. Okay. Commissioner Calderon,
Yes.
Elaine,
Yes.
Bella,
Yes.
Eric,
Yes.
Dana,
Yes.
Robin,
Yes.
Dimitri,
Yes.
Nancy,
Yes.
Matt,
Yes.
thank you, and Undersecretary.
Abstains and chose late.
Thank you.
Again, good morning, and definitely want to recognize that in addition to being in person, we have a couple of new board members that I'd like to recognize. In person, we have Michael Caljo, our DOI commissioner. Welcome. Thank you for the role that you have served and the role that you'll be serving with us. Recognizing Dana Sullivan, who is representing ANF and joining us online, if I'm not mistaken. Welcome, Dana. Glad to have you on board.
Happy to be here. Thank you.
Thank you. All right, the first item on the agenda is approval of our minutes from the September 12th meeting. I'll entertain a motion to approve the minutes.
So moved.
Second.
Okay. Commissioner Calderon,
Aye.
Elaine,
Yes?
Bella,
Yes.
Eric,
Yes.
Dana,
Abstain.
Robin,
Yes.
Dimitri,
Yes.
Nancy,
Yes.
Matt,
Yes.
Undersecretary.
Yes.
Thank you.
Okay, with that, the motion carries. And we'll continue with our next agenda item, which is our executive director report presented by Audrey.
Wonderful. Thank you, Elaine. Good morning, members of the board. And welcome to our first in-person meeting since February of 2020. It is wonderful to see people together again in person. And I, like Elaine, want to extend an especially warm welcome to our new board members. Dana Sullivan, who will be our ANF representative on this board going forward. Thank you, Dana. And Commissioner Mike Caljo, who recently started in his position as DUI Commissioner. I've had the very good fortune of knowing and working with Mike for many, 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 many years. And I'm thrilled about his return to state government, to state service generally, to the DOI commissioner role specifically, and to this board. Welcome, Commissioner. Going forward, we do plan on holding this kind of meeting in person once a year when we're deeply engaged on strategic initiatives. Before getting into today's agenda, I would like to share a few updates on a few areas of importance to the Health Connector. First of all, as you all know, we are in the middle of an open enrollment period and are prepared for what will be our busiest week coming up next week as we lead towards the December 23rd deadline for new enrollment and plan changes for the start of the new plan year. We had a smooth start to open enrollment, and so far it has gone soundly from the operations side. We are seeing brisk enrollment similar to last year's very busy pace and markedly ahead of what we would now call the COVID years from 2021 to 2023. We are already 96% towards our goal of 353 covered non-group lives for January enrollment. We have a lot going on over the next 11 days, including a string of visibility events at malls across the state, press events, and daily reminders to members to take action before the deadline. And our newly expanded team of navigators, assisters, and community specialists are busy and remain available to help residents all across the state. I will also note that our customer service center will have special hours next Saturday, December 21st, and will be open from 9 a.m. to 3 p.m. to help people complete their 2025 enrollments. This open enrollment is not only important for people seeking out brand new coverage, but also important for many of our existing Tufts Direct members. As you all know, Tufts is removing UMass Medical and Boston Children's Hospitals from its network. This is the largest one-time network disruption for members that we can remember. We know that this may cause disruption and hard choices for members. Many will be faced with the question of keeping their plan and needing to seek out new providers or keeping their doctors and by moving to a new plan. We continue to reach out to members to ensure they are aware of the changes, and through local in-person support from navigators and our customer service, have options to get assistance in making decisions for next year. We're also prepared for the likelihood that many people may not realize these changes have occurred until after they go to see a provider. We will be prepared to support and guide our members in evaluating their options if that is the case. We also continue to keep close tabs on potential changes to the Affordable Care Act space as a new federal administration in Congress starts in January. We're in close touch with colleagues at Mass Health and DOI and other state agencies that will similarly be navigating a new federal health policy landscape. We are also tightly synced with our fellow 20 state-based marketplaces across the country through the State Marketplace Network and other national resources that will support and inform our work in the context of a shifting federal policy environment. At this point, while we're closely following signals and developments for our own situational awareness, it remains too early to speculate on any kind of specific changes and how they will affect the Health Connector. As you'll hear during today's discussions, we continue to focus our mission on providing health coverage to everyone in Massachusetts. Our job and our responsibility to the Massachusetts public remains the same. We continue to focus on how we hold the line on coverage gains in Massachusetts and make our coverage services and experience for the residents we serve even more exceptional. With that in mind, the bulk of our time together today will focus on our strategic direction. At the beginning of 2024, this board approved an ambitious 5-year strategic plan that was developed with your guidance and the perspectives of our members, our staff, and policy and market stakeholders. Today, we'll check in on progress in year 1 and look ahead to the 2nd year of this plan that's guiding us. I'm endlessly proud of our team for delivering key wins this year, like growing our enrollment by a whopping 31% between the start and finish of this year, resulting in the Health Connector's highest ever enrollment in its 18.5-year history and the Commonwealth's lowest reported rate of uninsurance. Implementing a historic pilot program to expand Connector Care, which resulted in 55,000 Massachusetts residents gaining access to lower premiums and cost sharing. Successfully wrapping up a historic redetermination effort in partnership with our Mass Health colleagues, resulting in 192,000 people who lost Mass Health finding a coverage home with the Health Connector. And all the while delivering these public-facing wins, launching the first phases of an effort to improve our internal business operations and working to mature our business functions as a workplace, making our work more impactful and better supporting staff. Looking ahead to 2025, we'll walk you through our topmost priorities, including a laser-like focus on continuing to grow enrollment, executing the successful transition of our contact center, holding our vendors to the highest possible standards of performance and efficiency, improving and modernizing the customer experience, and continuing to chip away at cumbersome administrative burdens that we know stand between the public and a smooth on-ramp to coverage. Next year, we also look forward to finding new ways to incorporate the voices of our members and the public into our work and priorities in the spirit of nothing about us without us. As we'll discuss today, we also think this moment of increased strain in our healthcare system and market will call on us to partner together even more deliberately with our fellow state healthcare programs and stakeholders to address the risks of diminishing health coverage affordability and access to care. All the while, we'll continue to double down on our efforts to take the Health Connector's internal operations to the next level. With that, I want to thank you for your continued engagement as members of this board. I thank you for your support for the work we do every day, as well as the work we're doing to build an even stronger Health Connector for the future. I look forward to our conversation today and your thoughts as we look forward to next year and continued progress to improve our work and better serve our public.
Thank you. And while it goes without saying, I think it always needs to be said. Thank you, Audrey and the team, for just your tireless work on behalf of our members and obviously with all of our contributions. So thank you, appreciate it. Next on the agenda, we're going to hear a presentation on Smartronix, the Amazon Web Services used here, and it'll include a vote. And I just wanted to let folks know that we'll have obviously some time for questions, which I will manage through the chat as well. So I will hand it over to Trish.
Thank you. Good morning, Mary has, oh, no, he's still out.
Thank you all, and good morning. Nice to see everybody in person. So I will be asking the board to vote for authorization to pay for authorizing additional funds for FY24 for Amazon Web Services through Smartronix for fiscal year 24. The Health Connector contracts with the Commonwealth reseller Smartronix for Amazon Web Services for our contact center. This is a contract through the executive offices of technology services and security, which means it's a single agency procurement, but it could be contracted with multiple agencies. It does offer us a suite of cloud-based technology services that best supports our business goals and our operational demands. By leveraging this contract, we're able to rely on a vendor that's been procured through an open, fair, and highly competitive process. We are also able to leverage a 16% discount on our cost. Each year, we work with Smartronix as well as our contact center vendor to determine the cost for the upcoming fiscal year, and that cost is based on the previous year's actual usage. We use this for inbound and outbound calls, connect charges, speech to text, storage of call recordings, text messages, cloud email, and technology such as VPN, firewall services, and storage. We came to the board in June of 2023 with an estimate for fiscal year 24, which was $916,583 based on that previous year's usage. But in early FY25, we were told that we had an overage from the previous fiscal year. This overage is due to increased call volume, increased messaging, outbound calls that we did for the unwind. And we now have an overage of $357,297. We will be revisiting our estimates for FY25 and may come back to the board next year with some adjustments. The cost for the overage for this year does not have a material effect on our budget. So before I turn it over for a vote, I don't know if anybody has any questions.
Is it related just more to we had such a successful year enrolling people, or?
We did a lot of outbound calling for the unwind, a lot of increased robocalls and messaging, and that we used up the 916, and in the last quarter of FY24, we had some overage.
Trish, I know cybersecurity protections are an important aspect to all of the operations that the connector does. And in the landscape of sort of constant threats, I would expect that the contract includes continual firewall protections and
Correct.
items like that. Is there anything you'd want to expand on in that respect?
Everybody at the connector knows I am not a
Yeah.
tech person. I will turn it over to somebody from IT, but I know that is of utmost importance to us, so.
And if it's helpful, just to expand on that a little bit, we did do a cybersecurity assessment earlier this year that was looking at really across all of our systems that the connector controls, sort of distinct from HICS, which is managed by a broader administration-wide governance structure. So we'd be happy to brief the board on what we found and what we're doing to adjust, because as you know, there are emerging threats in the landscape that we want to be all over. So even broader than this particular contract, we're on that.
I think at some point, such a briefing in layperson's terms.
Yes,
I would love to
we
have.
can definitely do that. That sounds great.
I'm not sure how to raise my hand on Zoom, so I apologize. But did any of our increased volume have to do with like the Mass Health redetermination efforts? And so we think that maybe it might come down in FY25, given that the redeterminations have been done, and we were trying to make sure people had continuity of coverage between Mass Health and the connector.
Yes, so our call volume was close to forecast, but we did we did over 326,000 outbound calls for the unwind. So that would have contributed. We increased the number of robocalls. We did almost 1 million robocalls actually in calendar year 23, and over 700,000 texts. So our finance department will take a look at our actual costs and usage for FY24. We will factor in the unwind, take a look at membership as well as call volume projections, and that's how we will reassess our estimates for FY25.
Thank you.
Tricia, I would assume because of the uncertain federal policy environment, one could imagine actions that might require us to continue to do a lot of outreach to our members. So I would encourage you all, as you're thinking about what's ahead, and obviously we don't know, that we be mindful of that and probably overestimate in the hopes that that won't need to be the case.
Yes, we will definitely do that. And I would just say that those conversations across Marketplace are already starting to, again, without kind of overly hypothesizing before we know more, but kind of looking at best practices and communication volumes maybe needing to go up. If there are changes we need to get people ready for, tell them about risks of, et cetera. So I think that's a really fair point.
But if you have a 31% increase in headcount, you got to project higher numbers ongoing anyway.
Correct.
So do you want a motion?
So hearing no additional questions and seeing no other hands in the chat, yes, we're going to obviously vote on the Health Connector staff recommendation to the Board of Directors, authorizing the Executive Director to submit payment to Smartronix for additional AWS cloud services for the contact center for FY24. For a total of $357,297.88. May I have a motion?
I'm tempted to say round
So
it up.
moved.
I'll go with it. So moved.
Second. Commissioner Calderon?
I'm gonna go with I now.
Elaine?
I'll call you with an I.
Bella?
Okay, aye.
Eric? Yes. Dana?
Hi.
Robin?
Aye.
Nancy?
Yes.
We hear from afterwards. Okay, and under secretary.
Yes.
Thank you.
Okay, the motion carries.
I'm sorry, I didn't get to vote,
Oh, I'm sorry, Dimitri.
but the answer is yes.
Matt's a yes as well.
You know where you stand, Dimitri. The motion carries, and we will move forward to the next item on our agenda. The meat of the matter, coming back to the strategic plan that was agreed to by this board, and really hearing an update and having a conversation around the strategic plan. And so with that, I will kick it off to Nori to start us off.
Thank you.
you vice chair. Just have a second to log in here.
Absolutely.
Perfect. Okay, well, good morning, everyone. Thank you for joining us today. So as our vice chair mentioned, my colleagues, Erin, Trish, Marissa, and I are very excited to revisit our strategic conversation with you and those joining us remotely. The last time we were before the board was in September to have this conversation. So we're excited today to discuss our progress for the first year of implementation and discuss our key goals for 2025. We obviously value your input and we want to make sure that our strategic direction, aligns with the priorities of our board, of our members, and our several stakeholders. So today we'll go over some 2024 highlights, our 2025 goals, and we'll engage in a robust discussion. We have some questions prepared for you, hopefully not so difficult. We can advance the next slide. Perfect, thank you. Alrighty, so as a reminder to those who have joined us for this conversation before and an introduction to our newest board members, last year the Health Connector began the process of developing a 5-year plan intended to serve as a roadmap and provide a framework for what would be our agency's initiatives, policies, and practices. And the plan was developed based on several feedback we received from staff, management, stakeholders, our board members, and we really made sure that everyone's voices was included in this plan. And it outlines 8 broader goals that are associated and fit within 4 overarching focus areas that are displayed on the screen here. Those focus areas are, in no particular order: improve and modernize the applicant and enrollee experience, maintain and strengthen organizational structure and system reliability, improve equitable access to affordable health insurance coverage, and last but not least, deliver high-value coverage options to the residents of Massachusetts. So we'll be periodically coming back to you guys, as you know, as we're doing here today, having this conversation, making sure that we establish and align our focuses and priorities for the coming year with the goals that are outlined in the strategic plan. In addition, thank you. Okay. In addition to the plan, we also created a quarterly milestone report that tracks the progress that we've made on specific work streams within the connector and continuously measures the impact of those work streams that are already completed. So although they are quote unquote completed, there is obviously continued work behind the scenes, and we want to make sure that it is moving the direction that we anticipated, or vice versa, and see what adjustments we can make there. So you all recently received our latest edition of our milestone report. I will note that recently we added an impact analysis summary report, which again is where we'll be monitoring the impact using metrics and establishing baselines in the impact summary report that is attached to the milestone report. So with that, I will jump into an overview of our 2024 highlights. So over the past year, we've made significant strides in advancing our strategic plan, and we're just going to walk through some of those key achievements today. I'll do it at a high level. Erin will then do a deeper dive into some of them. So starting with our first focus area, improve and modernize the applicant and enrollee experience. We really focus on efforts of reducing our administrative burdens for our members and applicants. We engaged with Manat, who helped us determine what were the areas that we could work on. And we've been streamlining processes that have already showed us some positive results. So just one example that we'll share today is that we've seen impacts already in the identity proofing process. So we were able to expand our list of acceptable documents, and we're already seeing a decrease in the number of document failure rates. So now people are able to move, along the application process without getting stopped at the part where they need to verify their identity, given that we've expanded those options for them. So that has been a huge improvement for our members. In terms of the redeterminations efforts, as we know, in 2024, we successfully transitioned 192,000 Mass Health residents that were redetermined from Mass Health coverage to the Health Connector. How could we forget this redetermination period, right? So we use the support of our counterparts at Mass Health, our community organizations, navigators, several others. I won't name them all. I don't want to miss anyone. But this was obviously a very critical task for us that was executed smoothly, one could say. And, we were able to make sure that individuals had continued coverage during this time period. Moving on to the second focus area of maintain and strengthen organizational structure and system reliability. We've prioritized, as Audrey noted in her remarks, we've prioritized internal improvements by implementing business process enhancements and expanding staff professional development and wellness. I will note that these are things that have obviously existed at the Health Connector, but we are now making improvements to make sure that we can be the best possible. So these efforts are obviously aimed at strengthening our operational capacity, make sure that we're ready and equipped for a growing membership. When it comes to the contact center side of things, we did complete the procurement of a new contact center vendor. For those of you who joined us at the September board meeting, Trish walked us through that process, and we are now in the process of implementing the new vendor. And this transition to AHS, right, is designed to improve our member experience, hopefully aiming to be and wanting to be the best in class, providing that best in class service for our members and applicants. When it comes to the third focus area, improve equitable access to affordable health coverage. In 2024, we saw a 31% increase, as noted, in Health Connector enrollment, reaching the highest number of members in the agency's history. Can we just take a moment to celebrate that like that? I guess it's the benefit of being in the room, right? We can just do things like this. So yeah, I think that growth reflects just the demand for affordable health coverage. It reflects the work that the Health Connector staff have done and continue to do. So happy to share that figure with you all. And now, with special thanks to the Healey-Driscoll administration, the legislature, we obviously were able to expand our Connected Care program, and we were able to enroll 55,000 new members to that program. So we're making sure that we're expanding affordable health coverage, obviously targeting those populations that might not have had access to it prior to program development such as this one. Now, when it comes to moving on to the last focus area, deliver high value coverage options to residents of Massachusetts. We have had another important initiative in this year, and it was the integration of maternal health and cardiometabolic health into our seal of approval process. This will obviously make sure that our members have access and receive high quality care, especially those in more vulnerable populations. And the plan is to be able to analyze recently collected baseline data and understand what are the areas in need for future policy developments using that data that we have received. We also required a new communication initiative that is aimed at improving the interactions between our carriers and our members, making sure that our members are more aware of the free preventive care services that are available to them. So, really enhancing that interaction between our carriers and our members, our outreach efforts in 2024. So I will stop there just because, like I said, Erin will now go into a deeper dive of some of these highlights. So.
Okay, great. So thank you and good morning, members of the board. I share everyone's excitement being in the room with you all today and to be able to discuss this topic with you all. So I'll highlight some of the Health Connector's achievements from the first year of our strategic plan, and then we'll chart the Health Connector's course forward into 2025 with you all. So some of the work that will be highlighted as we recount 2024 are projects that have been completed, while others are bodies of work that are ongoing, where significant progress has been made, but we will continue to carry into 2025. All of this work, however, is setting the foundation for future Health Connector success. So as Nuri noted, beginning with the improving and modernizing the applicant and enrollee experience, Health Connector efforts to reduce administrative burdens for Health Connector members and residents was a priority in 2024 and remains a priority as we look into 2025. One of the first burdens that staff began tackling in 2024 are the additional challenges in the process known as identity proofing. Identity proofing occurs early in the application and establishes the person applying is who they say they are. However, some applicants, especially individuals less likely to have an established credit history, may need to submit additional documentation to prove their identity before they can continue with their application. So after closer review of the identity proving process and requirements, Health Connector staff recommended and over the last year worked to increase flexibilities and expand the list of acceptable form of documentation an individual can submit as part of this process. The revised approach, accepting a wider range of documents and enhanced flexibilities, took effect just last month in November, and already the Health Connector is seeing a decrease in the unacceptable document caseload. So that is the number of documents submitted are now being more likely to be approved as it compares to that expanded list. And there's been, as Nuri noted, a 46% decrease in the document failure rate.
Erin, what are you finding so far are the most important additions you made to the document list that are leading people to be able to be verified?
You know what, I will have to take that back, Nancy, to see which documents specifically we're receiving now that maybe are the newer documents and leading to that decrease in the caseload.
Who does the IDP, the carrier or the connector?
The Health Connector team, or so our contact center, we have dedicated sister lines as well. So the Health Connector does that process.
You just had to find my original birth certificate.
So
Sign up for a certain government program I won't name. I'm completely empathetic with this, so that's great.
Yeah, absolutely.
Make it easy for people.
And in addition to that expanded list, there are additional flexibilities around, you know, the most recent or original version and such. So this all just means that when applicants submit their proof of identity, fewer people in this first month are failing the identity proving process and being asked to submit, you know, a second or additional form of identity. So it's still early in its implementation and staff will continue to monitor metrics related to the identity proving process, but we are encouraged by what we are already seeing, where it appears to have a noticeable impact on how individuals are experiencing the application process.
Where did we?
I'm sorry.
Where did the number start at? Was it like a 9% rejection that went down to 4? Or was it like a 90% rejection that went down to 45?
Yes, so I believe the rejection rate, yes, around 2%. And yes,
Yeah, so it was very low, but just to kind of put a fine point on it, the people that get tripped up by this are people from typically like immigrant populations, lower income populations. So this is like an equity issue in action from an administrative perspective. So was low. Being someone who receives escalations from people who get stopped at this or fail to get coverage or get dropped from coverage because of it, numbers low, but slashed, and like it's the populations we worry about not getting across the line.
I mean, so many of these processes are set up assuming a particular life
Exactly,
cycle.
right, exactly.
Like I was born in Germany, which was why this
Right.
became like a big thing.
Right.
So even though it's 2%,
Right.
it's really hard.
Yeah.
So that's.
Same with
That's right.
income, like the system is really better designed for people who have a steady predictable income and all of that. So that's, we're just trying to think differently
Yeah,
about
it's
that.
right.
Doesn't allow you to move forward
Yeah,
anymore,
it's
yeah,
either
which
way,
is
right,
hard,
yeah.
right? Because
And then
then
people
you,
stop. Right,
exactly,
yeah.
you just give up.
This is too
Right, yeah,
confusing.
Well,
exactly.
because you're asking sometimes for things people don't have.
People don't have, or if there's a language barrier, it's harder for them, like, to,
Yeah.
you know, get that
So
help.
it's great.
okay. As part of the Health Connector's commitment to strengthening both internal and external operations and functions, several initiatives have made significant progress this year. As the board may recall, and as Nuri noted, the Health Connector launched its effort to develop standard operating procedures for the Health Connector's work functions. The first phase of this work identified that there are a total of 576 standard operating procedures for the Health Connector's functions across the agency. So the second phase is underway, and that's when the documentation of these standard operating procedures will occur. But as everybody noted, large number of standard operating procedures for the agency. So the Health Connector has also prioritized professional development and staff engagement, establishing over a dozen initiatives that promote across agency engagement, information sharing, opportunities to connect with leadership, and prioritizing staff growth and wellness. And the Health Connector has also implemented a more streamlined and improved approach to onboarding for new hires, establishing new trainings to set new employees up for success, while also developing business resources to support existing employees.
quick question, just besides making people generally happier, do you have a retention issue or a recruitment issue or anything like that?
I don't think we have either that are sort of out of step with kind of standard industry practice, but I think when we kind of looked under the hood, we saw a lot of areas of sort of HR and kind of personnel and development that could be, really were in need of a fresh look and kind of modernization. So taking that pretty seriously, and that's something we hear from staff, that they were really looking for more support around, again, development and kind of more consistency across the organization with respect to kind of how we grow people, how we support them in their roles, clarity around what the expectations are, and kind of the bigger picture for kind of how they fit into it. So that's.
Thank you.
And to add to that, we established an annual survey that began in 2024, just, mid-year, all staff, completed this survey, or were given the opportunity to complete the survey. So we'll continue to do that on an annual basis to check in.
Thank you.
Did any of the changes or improvements end up being codified in a document for employees?
So we did an updated employee handbook, which hadn't been done in several years, so that's one place that's a little bit more just like work a day type details. At this point, I wouldn't say there's specific documentation. I can give some thought to that. We have an internal business improvement task force that we've launched that's sort of cross-agency department representation, and so there's development of initiatives that are being documented and rolled out through there. But nothing that kind of rolls it all up in one place just yet, but maybe we will work towards that, and if it's something the board would be interested, but certainly we're gonna tie that up in a bow.
And how much are we bound by the standard state rules and policies in this area, and how much flexibility do we have because we're an authority? And
We have a lot of latitude because we are a quasi, both with, we have our own HR processes, systems, et cetera. So we're really kind of in our own universe. We've been fortunate to be able to tap into HRD resources and things like that where needed, but we're not bound to them. So that's sort of the more personnel oriented area of focus. On the kind of business functionality and business operations side with kind of developing standard operating procedures and the like, that's entirely kind of self-driven. I know there's many other state agencies that do initiatives like that, importantly so, but we're very much in our own kind of lane doing that.
How are you prioritizing the 576 business functions?
And I will say, I think that's likely a 4, just to be honest with you.
It's no different from any company or organization.
Right. We do incredibly complex work that requires documentation for a reason everyone around this table certainly understands. Training new hires, somebody leaves who's got single thread of knowledge about something, et cetera. So with respect to how we're prioritizing the order of actually drafting them, some of them are to kind of help inform operations we know are coming, right? So like areas of focus that we're planning to roll out next year, we really want to have those SOPs tied up. Others, just to be very particular about it, we have some staff that are retiring that have a lot of knowledge in their heads. So we're prioritizing what they know to make sure we're getting that on paper before they walk out the door. So it kind of varies, but we have been tried to be thoughtful about what's going to be most needed and most helpful earliest in the process. But I will just say selfishly, I'm extraordinarily excited about this project and very thankful to my staff because you can appreciate it's a big lift up front to document everything you know and what you know how to do, and sort of surfacing places where we actually may have people that disagree about what the process really should look like, but this process is helping surface that and create alignment and agreement. So it's a lot of work and time up front, but I think one that will pay off for us long term.
well, and addresses a major point of vulnerability is, for all the reasons you said and others.
Right.
It's usually not the work that makes people's hearts sing the most.
Right.
It's really, really important.
It's really important. Thank you for your support.
Okay, thank you.
Hi, Audrey, I had a quick question. Forgive me, I'm having some issue raising my hand. With regard to the knowledge transfer from those employees that are looking to move on or that are moving on due to retirement, et cetera, and 576 or so SOPs that you were looking at, what project, if any, are on the way to incorporate the knowledge transfer or those SOPs into business rules and the systems that you are building so that inherently the knowledge is embedded in the technology that you're rolling out as we continuously strive to improve our technology platform?
Yeah, it's a great question, Dimitri, and I would invite Trish if there's anything you want to jump in on. So I think there's the development of the SOPs itself, huge lift. That's kind of what we're staring down the barrel of at this moment. And then it's incorporating that into business requirements for our technology vendor contracts. It's incorporating it into making sure that becomes a part of daily work life at the connector. So it's not just this list of 570 some odd SOPs sitting on a shelf, but that this is actually incorporated to how people do their work and really comes to life. So it will become part of kind of business requirements and the like operationally, as well as how we're expecting staff to rely on these kind of new consistent standards. But Trish, I don't know what you'd add.
I mean, we're also working with our vendors as we develop some of these SOPs that maybe we don't have or that need to be updated with the change in vendors. So it's helpful for us to have their input to see how things will be so that we can have the SOPs geared towards, you know, where we will be once those vendors are in place.
Any additional questions on this focus area? Okay. So we will briefly review some of the progress made in advancing efforts to improve equitable access to affordable health insurance coverage through new or enhanced outreach initiatives. As Nuri mentioned, and as you know, the Health Connector successfully implemented and launched the Connector Care Expansion Pilot in January 2024. As part of its campaign to raise awareness for the significant expansion of state support, communications were sent to over 470,000 unique recipients. There are now 55,000 members currently enrolled as part of the pilot expansion population, and that they now have access to new benefits as a result. In-community supports grew throughout 2024 with the creation of a community specialist program, which provides in-community supports in 12 locations across 6 communities, and with the expansion of the Navigator program. The Navigator program concluded its re-procurement in mid-2024, adding 3 new Navigator organizations to the program, totaling 24 organizations. That's an increase of 3 from the prior year, and has over 50 locations throughout the Commonwealth. They offer support in 32 different languages, and that represents an increase of 11 in-person sites and 5 net new languages for 2024.
Can I ask, what was your source for the 470,000 unique recipients?
Sure, so those are actually communications that we sent out to eligible but unenrolled individuals that we were aware of in our system, as well as individuals who were in the 300 to 500% FPL range. So those are known individuals to the Health Connector that we
So you knew the 300 to 500%, you have that information?
So that's anyone who's ever touched the HICS system.
Okay.
It's not just people floating around
Yeah, yeah,
Massachusetts.
yeah.
That would be great to know.
Yeah,
That's anyone who is ineligible but unenrolled. That's like our term of art for anybody who's ever applied, been given an eligibility determination, but maybe never enrolled, or maybe they did at one point enroll and then they unenrolled, but the system still knows about them. So that's what that is.
And of the 55,000, you're able to, you know their income distribution?
Yes.
Yes. Is there anyone above 500? No, right.
Yeah.
But, okay, right.
And I will also note that for individuals who come in to complete an application, they don't necessarily have to include their financial information as well. And so messaging was also sent to that population because we don't know what that income threshold was. So just to cast a wider net.
Can attest that they're very persistent. I enrolled for like 2 months when I took this job. I still get texts like, hey, what happened to you? Like, are you interested? We have no cost insurance products. So.
Undersecretary Mahoney has been a very good case study. Shared many notes with me about it, which is great.
Yeah.
Thank you. So new Health Connector outreach efforts also focused on the gig economy, which is estimated to represent 600,000 individuals in Massachusetts. Outreach efforts include visibility events and info drops, for example, hosting a coffee session and sharing information about the Health Connector at the rideshare parking lot at the Logan Airport. So more of that, of course, on the horizon, but just one example from 2024.
Erin, just a
Yes.
question on that, you know, considering the independent nature of like how they work, does that cross into any of the small business products that we have as well?
So for our small business products, you have to have more than just you can't be a sole proprietor. You have to have an employee that is not related to you as well to shop through the Health Connector for Business platform. But great question.
But like, yeah, but typically like the creative economy and like that, people who are kind of, maybe doing that type of thing, that we do encounter those folks when we do Health Connector for Business outreach. And so think about that sort of as like a cultural focus for us in a certain way. But
Absolutely.
Here was more on the non-group side. Great.
And lastly, the Health Connector concluded the post-pandemic redeterminations process, as Nuri noted, having enrolled 192,000 unique members transitioning from Mass Health to Health Connector coverage.
Erin, what are our plans to figure out of all of this wonderful outreach work? Which parts worked and which parts maybe were less effective? And also across the navigators, I would imagine there are lots of wonderful lessons in each organization of what worked and maybe worked really well for particular populations. How do we capture that and share it?
Sure. So I know with our navigators, there's monthly reporting that occurs, and this of course captures the metrics of how many individuals assisted and more demographic information, but there are also regular check-ins with our navigator organizations. And that is not just with the Health Connector and a single navigator, but open to all navigator organizations where lessons learned and best practices are shared. There's interest in, of course, leveraging some of the experience of some of our more seasoned navigator organizations as we bring in newer organizations to kind of teach them what they have learned, what works for them, but of course, recognizing all communities are different and therefore organizations also need to kind of adapt to meet the needs of their community. With respect to measuring outreach and the effectiveness, you know, as we kind of sift through all of these different efforts, I know we have been focusing on a way to set up an assessment or evaluation, and certainly welcome input from others as we think about how to really zone in on which outreach efforts should we redirect more of our focus towards. Audrey, Marissa, or Jason, I'm not sure if there's.
This is something that the marketplaces are focused on at all.
Yeah, so I would say this is an area of focus for me as we head into 2025 too, because there's a lot new we've done in the last year or two, and there was an increase in investment as part of redeterminations. I think, you know, candidly, it's easy to say, well, it's difficult to measure because we talk to people in so many different ways. We're on the radio, people are seeing ads about us at their bus stop, they're getting mail from us. And then when they finally enroll, it's difficult to say what was the thing that actually pushed them over the line. But that being said, that doesn't mean there's not ways to do it. So I think we do just really need to buckle down and give it our best shot, even if it's difficult to completely parse it apart. We do a survey of new members periodically, and we ask them where they heard of us. So that's a place where they can communicate with us, so we can look at what the latest in that data set shows. So we can certainly circle back with you. And I know, you know, there's certain state-based marketplaces that, like us, are particularly forward-leaning on outreach. California comes to mind, and they do a fair amount of work trying to evaluate, you know, where's the best use of dollars when we think about this going forward. And I think we do have good information from our navigators. I think we could probably think fresh there a bit too, in terms of learnings, best practices, et cetera. Some of them might be hyper-localized, like what works really well with the Brazilian community in Framingham may not necessarily be what works well with, you know, you name it, other population in Holyoke. But I think it's still worth sort of teasing that out.
Yeah, I think both for our own, you know, learning and strategic investments going forward, but also we are the most successful state. So I can't help but think that there are things we should understand better about what is working that we actually could share. You know, the spirit of humility in every state is different.
Absolutely.
And maybe with a look back to 2017, what avenues are more comfortable for people in an environment of national unrest and uncertainty in terms of documentation, proof, you know, you're asking people to enroll with a government agency.
Yeah.
And, there's hesitation.
Yeah.
At certain times, and that'll.
Right.
Probably come up again.
Yeah, I think that's a great point, and some of the things that may have worked last year may be
Less
less
likely.
likely to work.
Yes, I think
Yeah,
that
no,
sounds
that's right.
public charge again, or the like.
Yeah.
Absolutely, that's a good point.
Great, thank you for those questions. Any additional questions before moving on to the fourth focus area?
I don't see any online.
So our final slide highlighting accomplishments of 2024 reviews the work that the Health Connector staff completed related to the development of a premium value plan designation for the small group market. The designation highlights the availability of existing high-value health insurance coverage available at lower than market average premiums when looking across similarly designed plans. Employers can filter to view the plans that beat the market average on premiums and may find that they could save up to 20% on their premiums when doing so. The premium value plan designation launched in November, so we will be monitoring how employers and consumers respond to the designation, but we'll also be focused on raising awareness of the premium value plan and its associated savings opportunities. We've had new advertising and marketing campaigns, which since November has had 2.7 million impressions. And we'll also note that we're looking forward to our upcoming partnerships with the National Association of Benefit and Insurance Professionals in 2025. So I'll pause there as well for any questions on that initiative and progress made in that space.
Can you just give a little bit more background on the premium value plan, like how is that designated?
Sure, and welcome, and Marissa, if you wanna. Go ahead.
Sure, so what we did is look within each tier, kind of inside and outside of the exchange, the market average for HMO versus PPO type networks. So we factored in network type as well, and then said which plans that are on our shelf are beating the market average, lower than market average. So there's quite a few plans that do meet that standard. And it's done in parallel with educational efforts about other ways that you can save money through Health Connector for Business, using the employee choice models that let people customize which plan that they want to enroll in, kind of apart from what their employer may have chosen, as well as our ConnectWell rebates that are available for employers that participate in wellness programs and have their employees complete wellness activities. And we recognize there's lots of dimensions to value. This is, really just one extra component to that, to say, how does the plan that I'm looking at fit into the constellation of plans that I hear about? When we talk about plans that are really high cost, that people are, small businesses are struggling with those premiums. How does this plan fit into that? Am I in that bucket with people who have high costs, or is this an opportunity for me to maybe save some money relative to what might be out there in the market otherwise?
So you're comparing it within metallic here, and you're also taking network into consideration, or just HMO versus PPO?
HMO versus PPO.
Okay, so if there's a health plan out there that has a much narrower network in, let's say, a gold plan, HMO, it's being compared to a full network health plan in the gold.
That's right.
Okay.
And just to add, oh, go ahead, please.
No, it's okay, go ahead.
I just briefly wanted to add a little bit of context for this. Was over the years, we hear a lot from the small business community about how much they're struggling with cost. Everybody's struggling with cost, as we all know. And one of the things that felt like it wasn't getting through in the small business community was the fact that there are lower cost options than they might be aware of. And even like for those of us who are in like the Merch Market Advisory Council over the last few years, there's a sense among some in the small business community, maybe opinion leaders in particular, that the individual market gets better deals than the small group market. And subsidies of course are there, but if you put that aside, all of the same variance there is in premiums that exist in the individual market are also available for the small group market. Now, a narrow network product may not be the right thing for a small business, just like it may not be the right thing for an individual. But what we were trying to do here was kind of crack open that misconception that there's nothing else available for small businesses besides those super broad and higher cost products, because that doesn't feel like it's getting necessarily through. So that was the attempt here, was to just draw some attention to it, even with all the caveats, like a narrower network product is a narrower network product, and it might not be right for everybody. But
So I just want to tease that out a little bit further. So I was trying to understand what's driving the 20% differential. And if it's primarily network difference.
Yeah.
I'm not sure that's a fair statement to say you could save 20% for a comparable plan. Because outside the connector, you can get limited network plans. So I'm just trying to understand what it is that's driving the 20% so that we're being transparent about, what the trade-offs are.
Yeah.
It could be the wellness, maybe it's the wellness piece, or maybe is the pricing any different, or is it all the same? This might be a question for the commissioner. I mean, the pricing of the connector plans, go ahead.
What I thought I heard though was that it was driven by network.
It is. So the 20% is, we took the average of what people are paying in the small group market writ large on and off exchange, but of course it's mostly off exchange.
Yeah.
Took that average and then compared it to what's available for that same AV, for that same metal tier through the connector. And you're right that all those products available through the connector are available off exchange too, but a lot of small businesses never see some of those plans because they're not really marketed in the same way. So the marketplace experience lets people see that comparison. And as we know, in both the individual market and the small group market, when people see that difference, they make really different choices than they do off exchange when they can't see everything. And again, I say that agnostic to what the right choice is for them, but just knowing when you put that in front of people, they do different things.
Which is why I like the phrase premium value plan versus value plan.
Right.
Because value plan assigns a blessing that is different than premium value plan because you're losing network for premium.
So I definitely agree. I think small employers don't know about these products, and I think this is a way to highlight. I'd be interested to understand the metrics behind it. And also, I don't know how it's communicated, but is there a way to communicate this is a lower network, more limited network, or something to that point? Yes, it's 20% below, but your doctor may not be in the network.
Yeah, my memory is that there's an asterisk or some notation.
Oh, okay.
And I think the question is whether it's broad enough or not. But I do know it's noted.
Why don't they know about?
I don't think it's marketed widely in the wide.
Broker insurance broker preferences.
I challenge that as a broker.
I set up perfectly. Let the games begin.
Brokers get paid the same either way. So it's really trying to convince the decision maker that
the government product is what.
No, it's about the limited network. It's about whether they're going to be comfortable with their employees who have sick children not being able to take them to Boston Children's Hospital. That's where it comes down.
We haven't seen for decades a limited network product that is attractive to the market.
But
we haven't been able to base it on a premium differential that has moved significantly enough to be attractive. Now, the theory is if you were able to create, I didn't expect to speak at all.
If you were able to our future too.
If we're able to create enough of a market incentive to drive the behavior that would make up for the limited network. But it's hard, especially in Massachusetts, given how concentrated we are. I think a limited network product has a lot more attractiveness in a larger state where you can sort of build out that network options.
It's also that the general public doesn't have a way of knowing that it doesn't matter if you get your CAT scan at Holy Family versus MGH, right? Like we don't have a way in which people can compare.
On quality,
right?
Quality.
And so then the only thing that you have is the brand.
You're exactly right.
Brand, you can be like, oh, my boss is cheap. They're only giving me this product that I can. Yeah, so it is tied to some of our lack of transparency. Well, I agree with that.
And the consumer is disintermediated from the decision. It's not a traditional market product, like buying a refrigerator, where you can shop on cost and quality at the same time. The purchaser is over here, the recipient of the care is over here. It's so that triangulation of the market relationship also becomes a barrier to driving consumer choice. Because it's hidden cost in large part to the consumer, through the, insurance mechanism.
And on the other hand, just in terms of capital, there's no way you're gonna get a 20% cost decrease without giving up
Yes.
something.
Yeah.
Right, I mean, you always give up something when you go cheap.
Yeah, and there's other ways to cut, like you chose to cut it on premium because it was responsive to the questions around market attractiveness. There's other ways that have better value, including cost share. Like you could do a cost share differential comparison. Basic services, it probably wouldn't drive behavior either. But it's an interesting, I don't want to get stuck on this in my mind because I feel like the perfect could be the enemy of the good here. And this is one way to do it, but it is interesting to see different cuts of the data, particularly around network.
Yeah, definitely. You're trying to get people to actually look at the connector for small groups, right? So if I were to ask, why should someone come to the connector for small groups? There has to be some reason for that as well, right? Whether it's convenience or ease, I don't know what the answers are to that, but I think.
Yeah, and I think there's a lot of answers to that. Like there's a lot of reasons they should come. There's an actual like discount they can get by coming and participating in our wellness program, like 15% off the top. And then there's the comparison shopping, being able to see the whole market, being able to make the apples to apples comparison. It's the only place where an employer can select a benchmark contribution and then let all their employees pick different plans, which is really significant. So there's a lot of good reasons, but we, as you all know, we continue to really struggle to break in. And just to go back to a question Nancy had asked about, why don't small employers know about the lower cost options? I think it is all the reasons people said. I think there's an inherent discomfort for some small employers around narrow networks. I understand that, I even share it. But I would also note a lot of small businesses in the state belong to associations that sell and provide health insurance and don't want any part of what we're doing and offer what they offer. And so a lot of the conversation about small business health costs don't ever direct to some of the solutions that exist and are on the table in front of small businesses, because there's these intermediaries literally intermediating between that knowledge, I think, and that awareness.
Yeah, like conflicting incentives and
Right.
loyalties.
Right.
And, I've looked at broker commissions for a while, so I completely defer to Eric. But last time I did, there were broker commission incentives to keep people away from the connector. There were the small business associations earning hundreds of thousands or millions of dollars in fees. So it's not that we're up against this, which is why the only two exchanges that have any significant small group business are the ones where they have a monopoly for the very smallest business. Small businesses have to buy in DC and Vermont, I think the only two. So.
Eric, from a insurance broker perspective, do you see the associations playing that role?
Well, I was having trouble following that description. Which role?
What Audrey was talking about, that there are associations that would discourage people from going to certain products because they're sponsoring their own.
Well, as an independent broker, most of us independent brokers just go to the carriers and the solutions that work best for the client. And as I mentioned earlier, we get paid the same across. We get paid the same across plan designs. Just trying to find something that fits the needs of and balances affordability and access. So I'd have to learn more about which association we're talking about, but I can tell you the independent brokers just are open to working with anybody. It's a hard problem to solve, affordability.
Yeah, I would agree with that. But I just think that we don't know about it, really, to be perfectly honest. I don't think we know about it.
Yeah, that's what
We're
I
not
was asking
looking at-
about the
I mean,
value proposition
in
of
our, I've never really thought, okay, I could get more commissions if we went, I mean, I'm sure there are people who do that and groups who do that, but we don't even really pay attention to it, and I think if we thought it was something that worked better for our clients, then we would do it.
Yeah, and the other thing to keep in mind from the broker community is that it's a pretty competitive marketplace. And as soon as a broker does something untoward, as soon as they start acting not in the interest of their client, there's plenty of other brokers out there that are gonna pick them off. So even if they wanted to do that, they're not gonna have a long life.
I just want to note that Dimitri is unmuted, and I know that there was some issues with hands, so just opening up the floor to anyone online, starting off with Dimitri.
Thank you very much. I think one of the questions I have, and I think I've communicated this in the past. When I'm driving through Boston, and if I'm anywhere near an MBTA bus or trolley, I see advertisement for the Health Connector for individuals who are uninsured to be able to obtain insurance from the connector. What I don't see, whether it's in Boston, whether while I'm watching the Celtics or the Bruins or the Red Sox, or any advertisement that promotes the shop product from the connector. So as a small business owner, and there isn't that same level of outreach taking place as it relates to the connector, and the opportunity for small businesses, even those that have access to various associations where they can obtain policies, to know that they can come to the connector. Perhaps we need to revisit what we're doing as far as the small business product is concerned, and what is the current marketing strategy, and can we piggyback the marketing strategy that we're doing for individual plans with that of the small business products, because I think, as it was previously communicated, is that most small business owners are not aware of the existence of the product, or the ability to also shop for insurance for their staff from the connector. So anything that we can do to enhance what's currently being done to create the same level of visibility that we are seeing for individuals to shop on the connector would be very helpful.
I'd just like to add one thing. I've been studying intermediaries and associations for forever. And also as a small employer, if Harvard Pilgrim and Tufts Health Plan at the time had arrangements with the intermediaries, Blue Cross decided not to. So they were separate. A group of 1 to 9, if you were to call directly Tufts Health Plan or Harvard Pilgrim, they would immediately direct you to Small Business Service Bureau or Health Services Administrators, HSA insurance. And then if you were to go to HSA or Small Business Service Bureau, since Blue Cross did not want to have a partnership with these two intermediaries, the product shelf would just be Harvard Pilgrim, Tufts, Fallon, and Blue Cross wouldn't even show up on the portfolio. So I think that's what you're saying, Audrey, is that a small employer group of 1 to 9 going to Small Business Service Bureau or HSA, the portfolio of insurers may not include some of the insurers that have a tighter network. Therefore, they don't really realize that those products are out there. And I would say the majority of 1 to 9s within those insurers go through the intermediaries.
Yeah, I think the connector role is really important around broadcasting options to the marketplace, because and this is where I think there's more value than not, no pun intended, through the value plan designation, is a way to illustrate the options on the market. They're not perfect, but they're options that the market should increasingly continue to know about.
So you're developing partnerships and relationships with the insurers right now as part of your strategic plan. You're having these conversations. Could one of those conversations be, how are you directing 1 to 9s right now, especially with point 32?
Yeah.
Are you directing them just to SBSB and HSA, or can you also throw in the connector?
It's a really good idea. It's a really good idea. And I just also want to acknowledge, Dimitri, your request for a deeper dive on the marketing kind of split and spend. We've kind of gone back and forth over the years about, you know, we have a finite pool of resources and kind of what the right distribution is between individual market focus and small group focus. So I think we would welcome that conversation with the board. Just wanted to thank you for that.
Great. Well, thank you so much. This is already a wonderful conversation. So looking forward to diving into 2025. So before getting started and handing over to Trish and Marissa to kind of walk through our kind of higher level Health Connector agency goals for 2025, I will just note that the organizational goals for 2025 are based on the Health Connector strategic plan, the agency's progress against the plan to date, and an updated assessment of the landscape that the Health Connector is operating within. Excuse me. All 2025 goals tie to at least one of the focus areas of the strategic plan. Oftentimes they tie to more than one. Equity is a component, an overarching goal of all Health Connectors work, and the agency intends to take an integrated approach to tracking and measuring progress against equity goals in 2025. As we walk through these broader agency goals, we are asking for your reactions, feedback, thoughts, and questions. Our intention is to incorporate your feedback from this conversation into how we focus our attention and achieve our goals for 2025. And I will just note here, this is, you know, as we move into 2025, the Health Connector will continue to focus on streamlining and improving the application and member experience and seamlessly implementing the new contact center vendor, as Nuri noted earlier. We'll also continue to think about strengthening our organization, remaining concentrated on standardizing internal business process documentation and improving internal training and development opportunities for staff. The Health Connector will also look to incorporate member voices into its work in new and meaningful ways and continue to coordinate with statewide equity efforts to improve equitable access to health insurance coverage. And we will look to engage with state and private partners to address current challenges of cost and access in new ways and continue our work to raise awareness of the Health Connector for business cost savings opportunities. So that's kind of, you know, you'll see as we walk through the goals, they kind of all tie back to those four strategic focus areas. And we're just sharing these questions up front because, again, we really want to make sure, as you've already been demonstrating, that this is a conversation amongst each other as we walk through these goals. So these are just some of our guiding questions to really kind of prompt discussion. And we are eager for your reactions, questions, and guidance as we review our goals for 2025. Pass it over to
So one of our biggest efforts of the Health Connector is to reduce the administrative burdens for applicants and enrollees. And as we've already discussed, we did an assessment to figure out what the biggest hurdles were for folks that were applying for coverage. We do have the new document processing verification process, which includes the identity proofing, which Nuri already alluded to. And we are also working with other agencies to combine and improve the member application. And we are making sure that the unique needs of the Health Connector members are taken into account as that project moves forward. To improve our operational stability and vendor management, we continue to raise the bar on accountability with our vendors in an effort to provide consistently best-in-class services for our members and stakeholders. We recently contracted with a new contact center vendor, and we're working with our incumbent vendor and the new vendor to ensure seamless transition that will not cause any customer disruptions or impact. We are incorporating lessons learned and best practices, such as running parallel contact centers for a period of time, where we're transitioning call volume over a little bit at a time, starting April 1st, 2025. The contract that we have has much tighter service levels than in the past. And we have a new emphasis on first call resolution. We're also working to improve our technology to create efficiencies and streamline the processes for our members. Overall, in an effort to continue with our vendor accountability, we're not just focusing on the larger contracts that we have, but all the contracts across the Health Connector. We want to make sure that we have the best contracts in place to improve our service delivery and quality. Part of that effort, we are centralizing a combination of vendor operations, project management, and procurement, so we can centralize the work and be efficient and be able to look across those areas holistically. And we are implementing a formal quality assurance team that will help us be able to ensure quality assurance across all the contracts of the Health Connector. Finally, once our new vendor on the contact center side is up and running, we are going to work towards a single communication tool. So currently we have text messaging that comes from one spot, email communications that come from another spot, we have robocalls, and we have the inbound calls that are tracked. What we will do is have everything together under in one platform so that anybody that calls will be able to see all of the different touch points that that consumer has had.
Can I ask a question?
Yeah.
Do you have mandatory requirements for consumer information flow into the connector in terms of email addresses and cell phones? Like what? So when you're reaching back to a consumer, it's reactive. So a lot of times, if you had to push messaging into consumers' hands, the ones that are already members through the connector, what do you have on? What are you able to access in terms of getting back to them?
So we have information that's in the HIC system, which is the eligibility system. We also have a platform through Salesforce where we record all of the information. The information comes over from HICS, we can update that. And I think, I'm not sure, Jason could probably answer better how we push messaging out, but we do have information in Salesforce. Which
So I think there'd be value to having available the ability to push out messaging in a dedicated way. And I just we don't talk about it too much now, but I'd be interested in learning standardizing approaches around email and text message to consistent with privacy and security requirements. But you know, we're talking about touch points for members, and I think there are increasingly times when you're going to want to reach a member because of a contract dispute or you know, a provider disruption.
Yeah.
And it would be great to know what the options are to get at those members.
We can definitely do kind of a status quo, like how does this work today? I know we have email, for example, for most of our members, so a lot of stuff does get pushed out to people by email, increasingly by text. That's a new space for us really over the last, 12 to 18 months because of redeterminations. So we could do kind of a roundup of like, what do we have and what do we do today and what's our future state vision for kind of how that starts to look different.
And I think assuming that we don't know which method works best for people, so multiple methods. I mean, you know, as from teaching, like,
Yeah.
I've given up on email.
Yeah.
Right. This generation doesn't work.
Right, those different populations respond really like, we'll never open snail mail,
Yeah,
or, you
that's
know,
right.
exactly.
They laugh.
Yeah.
Yeah, absolutely. Oh, quite, there's so many.
Remember when email was like like I know even early in the connector days, like we weren't that focused on email because even then it was like, oh, a lot of people don't feel comfortable yet with email. So times change quickly.
Yeah.
Dimitri?
I think as we start to look at that issue, one of the areas that we have to look at is for most people, they want to get the invite and they want to come back and retrieve the information. So as we start to look at security and how we're going to interact with our constituent, one of the things that we have to look at, and I don't know if that's on the work plan, is really we have to be able to authenticate who's coming back to receive the information, which means now that we need a greater we almost need two-factor authentication for the people that we're trying to outbound messages to, so that we know in fact that the person that we're sharing this personal information with is in fact who it is that we think it is. So security becomes an even greater issue as we look to share more outbound communication, especially sensitive communication. So I would be very interested in terms of our strategy moving forward for almost a reverse authentication to ensure that we know who it is that we sharing this information with electronically before we share that information, given the transient nature of some of the constituent that we serve and their ability to change phone numbers very quickly, et cetera.
Mhm. Yes, no, that's a great suggestion, Demetria. We can definitely do a deep dive with the board on that. And I will just say there are an extraordinary number of rules about what information we can put in what types of communication, to the point that it encumbers our ability to sometimes be clear and helpful with people. I will just say it all comes from a good place. It's in federal law, but for example, we have issues with people not being able to access subsidies if they didn't reconcile their federal taxes, and we have to be very coded in what we are looking at Marissa because she lives this world. We have to be very coded in what we can or cannot say in a communication to someone, about coming back into the application that they have to get into that has all sorts of security and kind of built around it for that reason. So your instincts are right on, and you have the support of the Affordable Care Act behind you and those rules. But we'd love to do a deeper dive and think about that holistically with you.
On the internal operations, I think we've already touched on the first three that are in progress, the employee training, strengthening the HR infrastructure, and the business documentation project. Upcoming is the launch of an agency-wide risk assessment project, and that will evaluate the Health Connector's legal compliance across business functions by evaluating obligations, existing controls, in areas where additional controls are needed to more effectively manage risks. And finally, for my piece, strengthening the data and analytics across the organization. So in 2024, the Health Connector launched a new data and reporting platform. And our data and analytics team is currently working on developing an agency-wide dashboard that will combine membership information, customer service performance, consumer experience metrics, so that we can have better data-driven decision-making. The team will also begin developing an improved enrollment report for the board of directors and other stakeholders. They'll be working to bring claims data in-house, and they'll be providing much more data and analysis for us to be able to respond to identify and respond to different trends.
Patricia, do you have any plans to talk to the board about what data we would like to see and how we use it?
We'd love
When
to
you
talk
revise
to you about that. And it is wide-ranging types of data we're trying to consolidate or stand up. Actually, the building we're in, Chia, has our, the all-payer claims database. It's been a long-standing dream for me and Marissa and many others at the Connector for a long time. So I think just getting it will be powerful. We're never currently able to answer questions about, utilization. We've been able to work with people like Bella in the past who have that data and we can work with, but to be able to look at health outcomes and utilization and counter data and the rest, but we would love board's input on what your essentially research or program questions would be, knowing that we have new analytic capacity and data, and that can help inform our research agenda.
Yeah, I think we're the target of a few of these reports to the board. I'm sure, I don't want to speak for everybody, but I'd love to give you some thoughts about what we would like to see, so that when you produce the board report,
Absolutely.
of what you think we should look at and what we would like to look at.
Exactly. We'll hear from Robin and then Matt.
Can you get data from the plans around the individuals that are in their plans now at all? Do they give you any kind of utilization data, or because it's just individuals and not groups that?
I don't know that we ever get or have even asked for utilization data.
Only around very specific
Like
targets.
cardio, metabolic things, and I'm
Yes,
just thinking
and
of
the data, yes,
through
or, we had asked about, some changes that we did to cost sharing for medication assisted treatment for substance use disorder. Those claims are very tightly regulated, and so just to know from the carriers when we zeroed out those co-pays. Did you see better adherence?
Yeah.
So we got some high level stats, but not kind of member by member.
Yeah, and even like GLP-1s and that kind, I don't know, it's just, maybe it's just nice to know things, but.
I would echo that too. I mean, in the traditional group world, you're constantly looking at trends and constantly looking at what's driving cost of care. Driving the cost of premiums and trying to, well, you don't have a silver bullet, you're trying to understand it and then make a dent on it.
Yeah, absolutely.
Yeah.
And I will just say, the kind of thing, just to keep going back to it, because we partnered a lot with Bella over the years in different types of analyses that we can't see, we don't have any sightlines into ourselves. And it might have been like a risk adjustment study or something like that, but I'm just recalling a few years ago when we could see with that help that people in connector care were not, in many cases, not even touching the healthcare system, didn't even have a single claim in a given year. And then when you think about who's in connector care versus the rest of the market, it's more likely to be people of color, it's obviously lower income people, and are not even availing themselves of preventive care. Like, this is all the work we're trying to do, is to bring people into coverage so that they can get cancer screenings and preventive care and the rest. And so having that kind of analytic ability can then inform the things that we talked about. Like, now we're working with carriers to do very targeted messaging to particularly lower income enrollees to say, did you know your preventive care is free? So it's just, there's so much, I think, untapped still there for us to be able to respond to things
And
like
just
that.
hold the comments in the room to allow for our online participants. So Matt, you have the floor.
Thank you, Madam Vice Chair, and apologies that I can't be there with you all today, feeling under the weather. So also not participating in this discussion and these discussions in the way that I would like to today. But this is an area, of course, where the GIC, we've done a good deal of work because we do have access to our claims data. And of course, we have, as you all do, good, strong relationships with the carriers with which we work. But as you go down this road, Audrey, if the GIC could be helpful in any way, I imagine that we can offer some insights based on our experience. We have a small but very mighty data analytics team, probably smaller, but I hope not less mighty than your team there. But I suspect there's some ways that we can be helpful.
That's great. Greatly appreciate it.
I guess I just want to add one thing. I know you had mentioned the all-payer claims database. And analysis that I've always done, I've always asked the insurance company directly for data. And there's reasons. The all-payer claims database, there's shortcomings. There's a big time lag.
Right.
So, you know, you might get access to the all-payer claims database, but it might be 2 years after the fact. And things are changing dynamically so quick that you kind of want data real time.
Yeah.
And then the other thing that the all-payer claims database does not include are non-claims expenses that are paid to providers. For example, management fees or things through risk-sharing arrangements. And so those things that are not claims are not going to be included in the all-payer claims database. And they can be anywhere between 3 and 10% of total expenditures.
Yeah, and so to that point, if I may, so for instance, at the GIC, we have very timely data on GLP-1 usage. I can tell you month by month what we've spent on GLP-1s, and it's critical for us, of course, as we're doing, for instance, premium development and spending projections as we are right now for the coming year, to be able to see in the last 2 months or 3 months of our claims data a significant spike in GLP-1s. Like, that is real-time data that allows us to make decisions in real time. And, you know, we're different than the connector, so there will be differences in the ways that we use that kind of data, but it does what data should do, which is inform decisions in real time.
It allows for good discussions. I mean, everyone's having these discussions separately. Matt, you're having them internally. The commissioner here is having hearings now on what's driving cost increases. We're going to be talking about prescription drugs shortly, I'm sure. And we have 350,000 people.
Yeah.
And we're responsible for maintaining the affordability and access for them. So there's a lot of integration we could do.
Can I just ask one clarifying question? Because I'm a little confused when we talk about getting claims data. Which of our members are we talking about getting claims data for? So we've got connector care members who are a separate pool, but then we have members who we help facilitate enroll in other products.
But connected care is not a separate pool, really.
Right.
It's all the same
Well,
people.
They're part of the merged market.
There's a
Right.
flag
Right,
in the
there's a
data.
flag, so
Yep.
there's a flag for anyone who enrolls through the connector, there's a flag.
That's correct.
Dimitri?
I think Audrey, to the point that was made earlier, one of the areas that has always been a concern to me, that continues to be a concern to me, is the fact that we are encouraging a significant number of our population to obtain insurance. And the question is whether or not these folks are able to afford to use the policies that we are encouraging them to get. And getting data that provide insight in terms of the connector population would be very useful. For me, it's we know the people that are getting their policies from us. Are they really using those policies to obtain care, or are they basically obtaining the policies for the bare minimum? And as we start to look at specific cohorts, whether it's folks who are using GLP-1s because they're diabetics, or folks who are using GLP-1 as a weight loss drug, can we look at our connector population and get a sense of the quality of services that they're receiving based on NCQA standards and NCQA guidelines, so that as we create our product shelves, we could also grade the content of the product shelf with the quality of results that we're seeing from our data in terms of what our patients are getting from a service perspective. So I'm in support of doing what needs to be done for the connector to have access to both claims data and non-claims based quality data that providers are submitting to the carriers on a regular basis, so that we can leverage that information to create a better product shelf and a more informed product shelf in terms of being able to identify quality with the products that we're putting on the shelf.
I think the goal is a really laudable goal. I think executing on it is complex and detailed, but let's go in. Let's go into that analysis and try to root it out. We won't be the first group that has tried to do that, because part of it is trying to figure out behaviors that are driven by multiple factors, some of which are not driven by the policy, but by other sort of real indicia. But it's where we should be thinking. You know, the topic of overall cost affordability also, I'll just say, and I know we're going to talk a little bit more about this, but overall cost and affordability is an important challenge for us to tackle. And then individual cost share impact and the impact on a consumer's ability to go and not self-ration their care is also critically important. But I would just note it's a hard path to go down and really do well because of the real lack of quality data around the access to the services. But certainly worth exploring and trying to figure out.
I mean, I would also say, I would hope we would prioritize connector care, which is where most of our members are. I mean, I think that our other pool of members, precious as they are and important as they are, I feel like we have a special duty, and we know that our connector care members are lower income. So just, we could spend a lot of time on the other 30,000 members who, many of whom are not subsidized and they buy for us for other reasons. So I would start with them. Yeah.
So moving on to engaging member voices, we've been working to more fully incorporate member and applicant feedback into our work on the principle that Audrey articulated earlier, nothing about us without us. So we've recently conducted listening sessions in Springfield and Worcester. We have another coming up in Lowell. And then moving into 2025, we plan to stand up a more formal member advisory council to obtain feedback from members routinely and consistently. And we'll be incorporating best practices there based on lessons learned in other states and from community engagement experts.
Do other exchanges have member advisory councils?
Some do, yes. And we know that this is kind of was a thing in Medicaid agencies. Now it's a required component of Medicaid programs. And so Mass Health has been going down this path. And I think we have things we can learn from them as well as from other states.
I mean, I would say just one suggestion as somebody who's been part of a lot of, consumer advisory groups, is we also have to have a commitment to really supporting people so that they can robustly participate. So I think as we're putting this together, learning from other organizations that do this work well, and obviously we partner closer with Healthcare for All, and I'm sure SCIU would be a wonderful partner, but you really have to give people the capacity to robustly participate through a variety of other supports as well.
Yes, very top of mind for us, unfortunately, because we're not entering a totally new space here. There's a lot of great resources and best practices on that, how you help people feel supported, even just logistically, like when you hold these and childcare, transportation, absolutely, all of that. And then similarly, top of mind for us has been, how do we make sure we're providing the right context and information so people don't feel like it's lip service or it's performative, like, oh, we want your thoughts, but actually like really getting a group of people that can engage in a really, deep way with us about the choices we face that we're all discussing, so that they're really kind of at the table with us.
Well, and we want to hear what they have to say, and we have a commitment to taking what they tell us and doing something.
Right, and telling them what we do with it, all of that.
Yeah.
No, that's a great point. I mean, my experience from being a community health center is what people on the ground want to talk about is very rarely what the institution or the board is talking about. Like so we have to be willing to change our priorities based on what they say. Yeah, it can be a challenge.
So working towards full coverage of state residents with high quality insurance has always been central to our mission. And we continue to work with sister agencies, carriers, and other stakeholders to make sure that our programs continue to provide high value care that members can afford. We've also worked to align our quality measures with Mass Health and in ways that are consistent with the state's quality measurement alignment task force to really concentrate the focus on meaningful improvement rather than on sorting out different administrative requirements. And we'll be looking for new ways to accomplish these goals in light of current market dynamics where we have both unknowns around changes in the federal policymaking environment, as well as very acutely known and felt challenges with cost and access right here in Massachusetts. And we've included on this slide barriers to dental and vision coverage. We know that that's an area of unmet need for our members that we would want to think about how to incorporate into our work more holistically. And then on the small group side, we're working on prioritizing some user-facing enhancements for the next year, including better capturing race, ethnicity, and language data, as well as improved comparison shopping for employers and brokers. We're also thinking about how we can continue to amplify our educational efforts to let small groups know about the plans we have and the tools that can help them and their employees save money, as we discussed earlier, including our premium value plan. And so we'll be partnering that with increased engagement with the broker community, including more consistent communications to brokers, improvements to our broker certification process, including training, and partnerships with brokers, starting with the National Association of Benefits and Insurance Professionals in 2025. And I just note that we have a new director for Healthcare for Business on staff who joined us in September, and we're excited to have him on board to really guide our work that's coming up in this space.
And really this slide, just returning to those preliminary questions, there are also 2 additional questions on this slide that speak to kind of now that we're through the high level agency goals. To again, conversation, your reactions, are there priorities that are missing as we walk through this? Is there anything that is missing? Are there areas where the board feels we should not direct as much energy as we enter 2025? So really an opportunity. We've had great conversation thus far, but an opportunity to again kind of engage in conversation on any of the goals that we just stepped through.
I'll jump in. I think this is a great grounding discussion, and the work that you've put out there is foundational, and thank you for that. I do think the greatest challenge that the health market is going to have across Massachusetts for multiple years is going to be the overall cost and sustainability premiums and related impact on cost share for individuals. And I don't know what the answer is, but I do think that there needs to be an increased focus for all of our roles, but for me, certainly at the Division of Insurance, but also within the connector through the tool set that you have around overall affordability and individual cost share. I would benefit from learning a little bit more about the grounding work that's already happened. But I do think that this would be the time to try some new and innovative ideas that would test the boundaries on the balance between, for example, full network products and limited network products through additional tools that we should study and think about using, maybe even around out of network default rates with balanced billing protections for members, meaningful protections that obviously would have to study from a legal perspective of the connector's ability to be able to push on. But I think we're entering in that, reflected on this, we're entering a period of intensity around cost that is going to dwarf many other issues. And I look to this group to partner and really think through innovation in this topic. So there are ideas that we should think about and place them aside, but I do think this is the time to really come back to the table with lots of new ideas that won't be new, but they maybe not have tried significantly in the past. So that's just my kind of, now ask me what those are, I don't know.
I'd say 2 things. One, I echo what the commissioner said about this great set of priorities and material as always is fabulous. You all did a great job presenting, so thank you for that. I have two observations. One is the uncertain political environment that we're all alluding to, I think is going to likely challenge us in ways that we can fear, but not entirely anticipate. So as we go into 2025, I think a certain amount of nimbleness and also realization that we're doing planning now for an environment that we don't really know what it's going to look like. So being able to pivot and deprioritize things that in a different environment we might be prioritizing it because. So I think thinking through really carefully what goes off this list of goals if we're encountering other things which must rise to the top because they're urgent. And then on the cost front, I am all for what the commissioner said about thinking innovatively. I myself think that we have already pushed the market on limited networks. And if we were to compare the networks that our members have available, they look really different than most other people in this state. So that makes me very wary of that. Although I think it'd be good to understand if that impression I have is correct or not. And in the way the market has evolved, we can't even do limited networks like a lot of different places. So to me, the challenge is how do we unite with other agencies and purchasers in a way to bring system change and not 300,000 people or 370 or 80 or sorry, I should have a number in my head.
350.
350? It's nice, but it is not big. It's not big, particularly when it's spread around so many different carriers. So I think our challenge is what are the policy levers that we want to put our weight and power and advocacy behind that we think actually would make a difference. So I think we should all be thinking collectively about that as well. And obviously supporting the commissioner.
Yeah, we're not alone. You got the Matt Bino, the GIC, looking at this too.
We're not alone, but we are alone if we come up with our little initiatives and Matt is coming up with his.
Do it together, right?
That is not the way that we're going to solve the problem that.
The HPC. And then Matt, did you not meet with the HPC every year to go over ideas?
We meet with them regularly.
Yeah, so there's a lot of opportunity.
Yeah,
and I think the point I'm making, Eric, is it's got to be concerted and collaborative effort, and we can't just be sitting here coming.
I agree.
There aren't any. I mean, you're all very talented people, so I'm sure there are some ideas. There's nothing we can do unless we do it with others in a really systematic way.
I think it would be beneficial to segment out, at least in our minds, what are the policy ideas that would require, like, further legislation? What are the regulatory ideas that are within current connector authority? And what are the regulatory ideas that can be effectuated through the seal of approval process, for example? Like, I view that as sort of that would be kind of a realistic set of initiatives that flow through to a wish list versus, okay, this can be effectuated through this channel, or this can be effectuated through the connector regulation in this area. Because the challenge that I've seen already in the space is people generally align on the items at a high level, but it breaks down as you get into what are the things that you can actually effectuate at the connect. This goes to Nancy's point, that the connector can effectuate. What are the things that the Commissioner of Insurance can effectuate? What are the things that Matt can do? And then what is our collective wish list beyond that point? And that would be helpful, at least for me, as a guiding tool for our discussions.
I want to give the floor to Matt, who actually had a hand up even prior.
Yeah, I could not more strongly support the comments from the commissioner and from Nancy on this. First to note, the first one I'll sort of emphasize is what Mike said at the outset, which is we're entering a different phase of our healthcare affordability challenge. And in some respects, I think the GIC may have a, I think the urgency of it and our line of sight of it is a little unique. And so I've taken and will continue to take opportunities to increase the level of urgency on this topic. So the GIC's premium trend has for a long time, given our size and our tools, has been below the merge market in the past. We've benefited from that. But last year our premiums went up 9.5%. And we are in the process now of developing our rates for fiscal year 26. We're unveiling our first look at that at our board meeting a week from today. And it's escalating even from the 9.5% from the current year. So, so we're in a different phase of this challenge, and 100% agree with Mike that this is, my hope is that it's temporary. I don't expect that it's temporary. And I think to Nancy's point, I agree that look, I'll speak from the GIC perspective, that we've had narrow network plans since 2010. We've had tiered co-payments to try to drive members with incentives to lower cost sites of care. We've had a $1,500 inpatient deductible for many years, and our members blow through that. So for myself, I question whether the traditional insurance tools are up to the challenge of the moment. And doesn't mean we can't and shouldn't keep pushing on those, but there is only so much that we can ask of a healthcare consumer. And I would be interested in the types of discussions, Mike, that you just talked about, which were, what are the things that we each in our respective agencies, what are the measures that we can take using those tools, right? And again, to Nancy's point, how having them happen in silos, uncoordinated, is an opportunity lost, right? So I think it's going to take a different category of solutions for us to navigate the next few years. And look, I think it's a moment of, I think, colliding crises. I've used that word a couple of times, that phrase a couple of times, where we have long-standing, persistent affordability challenges. We all know what they are. We have the benefit of the HPC and CHIA to give us real data grounded and thoughtful insights into those. We have a delivery system that is struggling, or I would say more precisely, areas of our delivery system that are struggling. Some areas are, I believe, doing just fine. And so I think there's a real important distinction there that can point us in the direction of solutions. But I think, after the collapse of Steward, that was, I'm trying to think of the right analogy, straws that break camels' backs. But look, there have been long-standing weaknesses and dysfunctions in our healthcare system that that COVID intensified, and now the Steward failure have intensified. So that we know the workforce challenges that exist in the marketplace; those are real in the delivery system. So you have that second category, I think, of emerging crisis, and then the uncertainty that Nancy talked about with the new administration. I mean, it's going to take nimbleness, as Nancy said, but it's going to take real innovative thinking and a different category of solutions. I'm all for that. This all sounds kind of grim, but I'm actually really hopeful and excited. I look at my colleagues around this table, and we've got the right set of people to address this, but breaking it down into its categories, like what can we do at the GIC? What can the connector do? What can the commissioner do with the tools that he has? We got a lot of smart people around the table. But I think the message I want to leave is like one of real rising urgency here. And it's going to take a different class of solutions that, in my opinion, shouldn't rely as heavily as we have on the past on the consumer's ability to act like a consumer that purchases groceries. That's my opinion. Anyway, I'll stop now. Thank you.
In a lot of these conversations that come up, people keep bringing up other states. I don't want to lose that either. If there are other states that are doing something that seems to be worthy of exploration, we should explore it. I saw there were studies done for the state of Vermont commission. I've talked to folks around this table about Rhode Island, what they're doing. Just like we're not alone in the connector, we're also not alone in Massachusetts.
And not alone with advocacy efforts with different groups and organizations. I'm thinking about the Health Equity Compact and the coalition of care and access. I mean, there's just both in the room and outside of the room connections that can be had in such a meaningful way, in quite honestly a strategic way, that looks like how we dealt with the crises of COVID, for example. I mean, there was unbelievable partnerships there that, unfortunately don't get maintained because of the next crisis or because of other things. And so perhaps it is, looking at maintaining what works well during kind of these unprecedented times.
I know we're short on time. I'll just add my voice in terms of the need for a collaborative stakeholder process. Because what we're talking about is disruptive and requires a degree of commitment from the best and brightest that we have in Massachusetts in all of our fields, insurers, pharmaceuticals, providers. And that's hard to do without a collective commitment to address those issues. At the same time, the connector has the work that they need to execute on. You're flying the plane at the same time as wanting to have these same conversations. So I honestly think that there's a value to having sort of a two-tier. There's the what can we execute on now, and then what are the valuable principles that we want to move towards over time that are going to require broader stakeholder commitment. Because it it is an opportunity, but it's really gonna be very, very hard to execute on it.
I think that's well stated.
Other thoughts, particularly online, other thoughts?
It's fun.
Better close while you
Yeah,
can.
close. Did a great job. Bring it home.
With that, on that note, obviously wishing everyone on the board, all staff, and our members, an amazing end of the year that's full of peace, rest, as we get ready to work in this next year, as usual. And so, with that, I guess I will entertain a motion to adjourn.
So moved.
Okay. And
Ready? Oh, Commissioner Calderon.
Aye.
Elaine.
we.
Stella.
Yes.
Eric.
Yes.
Dana.
Yes.
And Robin.
Yes.
Dimitri.
Yes.
Nancy.
My friend Mike, aye.
Matt.
Yes.
And I'm the secretary.
Yes.
Thank
Take
you.
care.
Thank you, everybody.
Thank you.
Thank you very much. Thank you, Kathy, for coordinating our first in person and have you.